Weaning meds in patients that do well. I'm going to present data on a prospective intervention trial in which we based the taper and stop regimen of maintenance therapy on a biomarker, in this case IL-18 levels, in a multi-center trial in the Netherlands in the past 6 years. And I think our data also provides some data, really interesting data on patients that did not do well on anakinra monotherapy and were a kind of a, let's say, difficult to treat patient. So I will try to discuss a little bit of the implication of the study on that as well. Let me see how this works. So we have seen in the past 15 years actually that the introduction of biologics and of also of JAK-statin inhibitors really improved the outcome of our patients. The response to these treatments have also really gained important insights in the mechanisms of the disease in the different subsets of systemic JIA and of Still's disease. And I think we learned from our cohort in the Netherlands, but also from other cohorts, that the earlier you start a targeted treatment, the better the response is, really proving or at least putting some evidence for the existence of a window of opportunity early in the disease. In Utrecht, we have been treating patients with first-line treatment of anakinra, so without the adjunction or concomitant use of corticosteroids in every patient, since 15 years. And since 7 years, this is part of a national protocol. So we are treating in all 6 academic centers in the Netherlands in the same way. We have previously published data on our cohort, first in 21 patients, later in 42 patients, showing that this approach is actually very effective, but it's also safe and it really reduces steroid use. We saw responses, so complete responses with clinical inactive disease in 3/4 of our patients after 3 months on anakinra alone. And after 1 year, we saw 70% patients of inactive disease, not all of them on anakinra alone. Some have had concomitant corticosteroids, but in a lower dose than we used to do, or switch to anti-IL-6 or a long-standing IL-1 blockade. Part of our protocol actually that we introduced 15 years ago, as part of it, it contained a promise to the insurance companies that paid for this approach, that we would try to taper and stop maintenance therapy in the first year, if possible, in very well responding patients. And we did that first just unbiased, and we found out that if we did that in around 3 to 6 months, 50% of those patients who were in clinically inactive disease on the drug immediately flared, typically within 1 or 2 weeks. Really reflecting the idea that these patients were in clinical inactive disease maybe, but had subclinical disease activity while on treatment. And when we, in hindsight, analyzed these patients, we saw, and these were very small numbers, we saw that the patients that had that flared after stopping the drug, that they had higher levels of IL-18 compared to those patients that had a successful taper and stop. And this was based on low numbers, but with a cutoff value of around 1200, we thought that at least we could make a new protocol and try to prove that and see how it performed in clinical practice. And this is exactly actually what we did in the past 6 years. And the important addition here is that we did this in a national way. So that's all I already said. So the question of this ESTIS trial, early stop of targeted treatment in systemic JIA, is does the level of IL-18 aid in the decision making of who's safely able to taper and stop treatment in patients in clinically inactive disease. We applied the PRINTO criteria, so not the ILA criteria for inclusion. 6 centers in the Netherlands, starting with first-line anakinra in all of the patients. Important inclusion criteria was when they had a coincident diagnosis of macrophage activation syndrome at time of diagnosis. So they would, of course, require the addition of high-dose steroids anyways, and we excluded them from the intervention part of the study. And here's the study flow. I don't think you can see my pointer. But you can see that we asked to all patients in the Netherlands in these years to enter the study in the open label lead-in, and we had a follow-up of all of these patients, and only those patients that in all of the patients we started anakinra first line in a dose of 2 milligrams per kg, and in those patients that made it to 3 months in clinical inactive disease without the requirement of corticosteroids, we reconsented them and asked them to enter the intervention phase. And the intervention phase consisted of 6 months maximum, in which monthly visits were scheduled in our clinics. And we assessed again whether they were in clinical and active disease, but also measured their IL-18 levels. We did it centrally in our lab in Utrecht. The Netherlands is a small country, so it's easy to find. We fed back the results within 1 week to all of those physicians, so they were able to, in a daily clinical practice, to really implement this strategy into their care. And if the biomarker was then lower than 1200, we tapered the drug for 1 month every other day and then fully stopped without remeasurement of IL-18. If the IL-18 was higher than 1200, we rescheduled the patient for 1 month later. Any patient that made up to 9 months after the diagnosis and of start of anakinra, who was still in clinical and active disease but had persistently levels of IL-18 during the complete intervention period, we tapered and stopped anyways. At least we discussed with the treating physician and the patient, telling them and discussing that we did not know what their chance of relapse would be, but that in every other center we would probably taper and stop the drug, and taper and stopped the drug anyways. And of course we had a very close follow-up up to 2 years after the start of treatment. So these are the results. We have 66 new systemic JIA patients with 45 patients entering the intervention phase. So 21 patients, and this is a mixed bag. They showed a more or less difficult to treat disease course in the first 3 months of the disease, excluding them from entering in the intervention phase. You can see that the number of males and females is pretty much equal. And what is also apparent in the subfinal row is that the time between onset of symptoms and start of anakinra is really, really short. It's only 23 days, so it's only 3 weeks after the start of the first symptoms. And also important to say is, just in line with our previous publications, 30% of the patients in this national cohort of 66 did not have arthritis, a diagnosis, but were allowed as part of the Printo criteria to enter this trial and to start the intervention. So these are the data and the numbers. You can see that the number of patients achieving clinical inactive disease with anakinra monotherapy is completely in line with our monocenter study. It's 73% versus 71% in the monocenter. 45 patients entered the intervention cohort, clinical inactive disease on anakinra only. And of those, 40 patients reached the levels of IL-18 below the threshold within the intervention time frame of 6 months, and they were tapered and stopped according on the IL-18 level only. 5 patients, and 80% of them had a successful taper and stop, while 20%, so 8 of them, did experience a flare of the disease. All of them responded again to anakinra reinstallment. 5 patients had levels more than 1200 picograms, 4 of them during the complete intervention period of 6 months, 1 minute. And one of them developed macrophage activation syndrome while in the intervention period, but still having elevated levels of IL-18, so that is conceivable. And of those 4 that finalized the intervention period, 2 of them immediately flared and 2 of them stayed in clinical and active disease afterwards. So overall, IL-18 with a cutoff of 1200 picograms per milliliter in our hospital significantly increases the percentage of patients with a successful taper and stop 1 year after anakinra monotherapy. If we compare that to our historic cohort data of 47%, this is a significant difference. And also important to notice that with a follow-up of 24 months in all of the patients, we can see that 97% of those patients that successfully tapered and stopped maintained their response during the follow-up of our study. Not sure why this animation is this way. I messed up a bit. So the Utrecht protocol, starting anakinra very early as first-line therapy, is highly effective, also now shown in a national multi-center prospective study. The addition of IL-18 with a cutoff value of 1200 picograms per milliliter significantly helps in the successful taper and stop of our patients. Early taper and stop, of course, reduces the duration of treatment and the amount of injections. And I think our study also provides some important information on the disease course of the non-monophasic patients, those 21 patients that did not enter the intervention phase because of, I'm sorry. Very important also, we have not seen any reduction in the incidence of MAS. So this is also an important observation. Last slide maybe, because we have many IL-18 data points during the first year, and we try to model them based on individual spaghetti plots, as you can see here. And these are in the lower right part of the slide, individual patient, but if you group them together, you can appreciate that those patients in red are the 21 patients with a mixed bag, difficult to treat. And the patients in black are those patients very well responding to anakinra. You can appreciate that the slope, the downslope of IL-18 in the first 2 months already predicts the course of the disease in the first 2 years. And that's what I wanted to show. Thank you.
Thank you. While they bring up the slides, if anybody else has any monitoring and treating lung disease, consensus processes at their centers, or like they've discussed it and they have a process, if you want to share, please email it to me. We are putting together a deck from the different centers that we've received so far.
I can see from there. So. Okay. Sorry, how do I? Green? Okay. Oh, this. Okay. So I think, this is just really clinical. I brought a couple of my patients, just what I did with them, different patterns, which some have a very prolonged periods in between their episodes. Some have, I call them recurrent but still persistent, and some are total persons. Like this patient I want to share, 18-year-old with diagnosis of stills, initially very high inflammatory markers. IL-18 was about 9,000 range and CXCL9 was normal, and started treated with anakinra, and every other day after 4 months. Then, he did really great, everything normalized, he's feeling great. So after 4 months, after staying every other day, I did actually 3-4 months of every day, and then every other day for 4 months. And then I said, he's ready to flare. This is going to be one-time thing. And then after 1 week of stopping, he flared. So this is another patient that presented at age 4. This is someone who had persistent disease, multiple MAS episodes, and now evolving into autoimmunity, actually, intermittent and prolonged steroid courses, needed anti-IL-1 therapy, tacrolimus, and then recently JAK inhibitors. And the thing with her biomarkers are always had elevated IL-18 all these years. Even with clinical remission, she remained around 40,000, sometimes 60,000, down to 20,000. Didn't really over time correlated with the ferritin level, other markers that we use clinically. So this patient had prolonged periods of on medication, obviously, but prolonged periods of clinical remission, but her numbers being elevated. Recently, with her IL-10 level went down to 2,000. So now I know that over all these years, it can go down all the way to 2,000, but then how do I explain when she remains on clinically well in between, while IL-18 still is elevated? Another patient, again, diagnosed with Still disease, 22-year-old, presented with MAS features, and just actually after having 3 episodes of this MAS features, first one self-resolved, and then second episode needed anakinra and steroid therapy, and then after third episode, she had a prolonged hospital stay, and tofacitinib was added, and anakinra was stopped actually even before discharge, and then her tofacitinib I've been weaning. She is actually weaned last 2 months and doing great. And her IL-18 levels and CXCL9 ferritin, I just put it there. Now all the way down to, actually in the last one checked was 2,000 of IL-18. CXCL9 is around, I think, 600, and ferritin is lower now in normal range. These are the two young patients. They had actually around the same time they presented. One was at 7 months of age, started having MAS and systemic JIA diagnosis, treated with anakinra, and this anakinra weaned over 18 months, and with every other day, then every 3 days, then I stopped. Her IL-18 and CXL levels are moderately elevated. Then everything normalized, and she's been doing well. Now she's actually 4 years old. And then other patient 5, is 20-month-old, presented with MAS features, and initially, both steroids and anakinra was started. Steroids for about 2.5 months, then anakinra for 5 months of daily. We weaned down to every other day, and then every 3 days, about for a couple of months each. The IL-18 level initially was very high, so I was very concerned that, maybe this patient is, and he was quite sick at the beginning, going to be requiring, or the flare is going to happen. But again, when I met him, he was 20-month-old. He's 5-6 years old now, actually now 6, doing really well. I think I will stop here since we have a lot of, but I think we just have to, there's a lot of discussions how to manage these patients. This is my clinical experience. Some patients seem to do well. Some, I think that they're going to do well, and then they still get another flare. So I just wanted to, I'll just want to thank my team, obviously, at Boston Children's Hospital. It was a bit of a rush.
Can you start with Yamona giving your perspective a little bit?
I had to write a few notes because my brain is about as full as everybody here. Okay. So first of all, we're a small center. We see about 60 patients a year. And I think the discussion about weaning starts at the very beginning of the relationship. So as we're introducing systemic JIA, we're talking about when we think we're going to be weaning medications. We happen to have access to an in-house cytokine lab. And we started a process a number of years ago, probably about 2 years ago, where we order IL-18, S100 proteins, and HLA taping on everybody at the start and follow IL-18 somewhat regularly. It's not predictable, though, and we should do a better job of standardizing that. So I know personally I have felt better when IL-18 levels are below 2,000 or 3,000 before I start to wean a patient. But I think in general, we appreciate a prompt approach, quick to clinically inactive disease. Unfortunately, we also prefer a prolonged period of clinical remission on medications, which I think might be a little more excessive compared to what you presented and what your area does. I think we're probably hoping for more like 2 or 3 years, frankly, especially if there are high risk factors. But I think our attitude is similar to what came out in the CARA survey from 2019. A lot of the same factors influence us, right? So if difficult intolerance to medications, difficult, frequent recurrences, flares off medications, all these things impact whether or not you're going to wean sooner rather than later. And lastly, I agree, they fall into easy category or not. So before IL-18, we had patients who it seemed like a little whiff of anakinra, treated them, right? And you felt really comfortable perhaps weaning at 6 months. But the other patients that are difficult to treat, it's really tough. And I think we all have the same anecdotal experience that you have, right? A patient who's been maybe treated for 4 or 5 years and take it away, and 6 years later they present with arthritis. They did great that whole time, right? Or you treat them for because they're easy, and then 9 months later they present again with the flare of disease. So I think these anecdotal stories are pretty persistent across time. And I just want to bring up one other thing. I think the other thing now that we are, gosh, I want to say 12 or 14 years into this concept of difficult to treat disease that we now all recognize, there is now a cycle of people who are fatigued. There are parents and children who are fatigued. They're tired. And sometimes, in my experience, weaning comes because they're tired and they've been through a lot and they just don't want to do it anymore. So there's a whole aspect of patients who are not adherent because they just don't want to take them anymore. So I'll remind ourselves that these are 2, 4, 5-year-olds. They don't have a lot of control, and they get to be 8, 9, 10-year-olds. And now they have a little say in things and they don't want to take anything anymore. So I've had that experience as well in kids who are stable. And that's unfortunate. So I think we need to address that as well.
Actually, I rushed my slides, but adherence was a little bit of, my slides too, because that, I agree with the tiredness and so on that comes.
So Baz, when you go back to work next week and you have a new patient with the SJIA, do you give anakinra or anakinra plus steroids? And what do you tell the parents if you go for the former? I.e., what's the likelihood they're going to need some steroid at some point?
No, it's a very good question, Paul. So I think our approach showed that we can do with less steroids than we used to do, but I don't have any problem with a short period of steroids in the first weeks, specifically as we have seen in our data that, for example, the incidence of MAS is not come down at all by using the first-line treatment with biologic. And I'm not sure whether you can affect that incidence by a short period of steroids, but I would not mind at least trying this.
So to be clear, you tend to still give a bit of steroid with the anakinra to get them started, or?
Oh, we have still, these data are now out a little bit in our center. So we have seen new patients. We still start with anakinra first line, but we are not so difficult anymore in preventing in all our patients a little bit of steroids during a really short time. So a couple of weeks is totally fine.
Yeah, I think more and more we start with anakinra too, because also if there's especially a question of could there be an infection, could there be something else going on, and so on patients we think it's going to be stills, and then add the steroids if needed.
And what do you find in those patients where you're a bit nervous about, getting the diagnosis wrong and missing a malignancy, So you give them anakinra. Do you observe that, my God, they're so much better and their bloods are whizzing down? Are you ever in the situation say, oh, well, maybe we don't need steroids? Or is it still that you say, actually, I'm going to add it in?
All of those, yeah, they do well and go home on anakinra maybe another month or two, and that they're fine. But some, also need steroid to add once the other things are ruled out.
So I think what I'm hearing from both of you, that steroids haven't gone away. I think we all agree that anakinra is first line. That's, that's what we all do. But there's, unfortunately, or fortunately, depending, still steroids are there up front.
Bas, I missed probably something, but you said you taper and stop, or you stop directly?
We taper and stop. So the protocol consisted, but they were linked, of 1 month every other day, and then full stop.
Okay, because
but the IL-18 determining to enter the taper stop phase was only measured once. So we did not repeat it. Well, we repeated the measurement, but not deciding then to prolong the taper phase. So the taper was only 1 month.
That's very nice data. Just one question: could you correlate this to the S100 molecule? So is it Could you confirm the data which came out a few years ago?
Yes, so we are, we also have measured S100 data, CXCL10, not 9. We can measure 9 as well, IL-6, and we are now correlating and improving a biomarker panel instead of IL-18 alone.
So will it improve at the end?
Well, in hindsight, we now only checked S100 levels at diagnosis and at 3 months, and that does not really affect.
I heard a couple people yesterday, I think Lauren mentioned it and Randy mentioned it, that they're often now starting methotrexate with new onset patients, and I think Bryce has mentioned that to me also. And I wondered, given, we used to use methotrexate all the time because it was all we had that worked, and now we don't because we know it doesn't work for the systemic features of the disease. How much of that could be related to some of these differences that we're seeing, that we don't have that sort of background sort of wet blanket on any funky T cell activation that you might see from biologics. So I'm interested in if others have had that approach and what they've thought about it.
May I start? I totally agree with you, Grant, actually. So having seen the data that the slope of IL-18 really determines already quite early whether you are difficult or the chance that you will become a difficult to treat patient, makes us also start adjacent methotrexate in high risk patients, so in young patients, again in the last 1 or 2 years.
I'd say I'm doing something similar. I think whether to use steroids or NSAIDs, it depends a little bit on the severity at the start. I don't automatically assume they need it, right? But even in a patient who has, say, high IL-18, high risk factors, I might consider starting methotrexate at the start. And we often are delayed anyway with biologics, right? There's a couple of weeks in there. So I've sort of become a fan of that approach. I happen to have a patient recently whom I did that approach with, who did fantastic on canakinumab, and then out of the blue had the very classic reaction. And by the way, had HLA typing positive, had a negative chest x-ray at the start, and was 2. And at 9 months, had a reaction with eosinophilia on canakinumab, and now started her trail of lung disease that continued to progress. There's one thing that I'm doing differently, though. I'm thinking more about just optimizing. So I'm triggering an optimizing kind of concept with a lot of patients. And I am taking some people's biologics away when I see that they're consistently triggering and triggering. And I'm finding an opportunity when I happen to be giving them a lot of steroids because they're flaring a lot anyway, and I'm giving them steroids. And I think the one difference is we now have access to kinase inhibitors and emapalumab, and that might be different than the experience you had early on or many people experience. So I think having those 2 tools allows us to potentially pull away biologics just for an observation moment to see if there's any chance they're triggering this problem. And so I've had 3 patients now in which I've pulled those away, and they are doing quite well. I will admit 2 of the 3 are smoldering, but I'm hopeful that they can be away from their IL-6 and IL-1. So.
I think I do the same, very similar. I mean, I've been adding methotrexate to if systemic it's going to be a little longer term. It was my practice for many years, 15, 20, and I always thought about T cells and actually itching the eosinophilia. I thought calming down T cells will help the IL-5 go down and things like that. That was that I did. But I agree, sometimes even with that, taking medication away depends, again, clinical picture. Even if you don't know the DR result, you will, if you need to, you will change, modify, stop, or add things. But again, I don't think there's going to be one way of, if this is this, and you have to do this, because there's patients are so, like all these 6, all the patients, they have different flavors of things, like there's difference. And you kind of recognize that. And I usually tell my patients that it's going to take a year for all of us to recognize how this inflammation in you is going to behave. And then we'll make decisions. I'm fine.
I have a question. This is Mike Umbrello. Boss, you said that the slope of the reduction of the IL-18 following therapy predicted response. I'm wondering whether that indicates that on an individual-to-individual level, elevation of IL-18 is indirectly correlated then with that, because the higher the IL-18, the more potential slope slope reduction you could experience, as opposed to lower elevation theoretically would not be able to have such a slope. And so I wonder whether you found a correlation with initial elevation of IL-18 as well.
So we checked the chance of the levels of IL-18 at the diagnosis and the chance that you have a monophasic disease, which is clinical inactive disease at 1 year and clinical inactive disease or disease remission, so off therapy at 2 years. It's not associated with the initial first measurement of IL-18, so there's complete overlap. So one measurement of IL-18 is not predictive of a monophasic disease course, but the slope in the first 2 or 3 months is indicative. And for your information, we also genotyped all of our patients, including the HLA-DB115 allele, and the chance of having a monophasic disease course with this type of regimen is completely the same whether they are carrier for HLA-DB115 or not.
That's really striking, boss.
We also have one patient with IL-1 of a systemic DIA-associated lung disease, which is, of course, HLA-DB115, which could fit.
I mean, I just scratch my head and think about HLA-B27, right? How many people walking around have HLA-B27 that don't have something? But then again, of the people who have the thing that's associated with HLA-B27, how many of those people have HLA-B27? We say, don't check HLA-B27, right? That's always the answer, don't check it. But we're in an emerging field where something new is happening that we don't understand. And so that's the reason that I advocate for checking it.
I think there's consensus that we should get grip on the risk factors for a refractory disease course, and that includes HLA-DRB1 typing our patients. But be careful in what it means.
So it's a parent online. She's saying, my child is on MIS 825 for more than 3 years and doing very well with this. SJIA and LD both are stable since 2-3 years. Normal IL-18, when should we consider to wean the infusion? All his labs are normal now. Will it be the risk to wean and it might not work anymore again? Or can we slowly taper it?
I mean, I think it is really individual. Like, you need to know the full story, and when you're treating a physician. Like, I have a very sick patient after a couple of years now on many medication. We are very slowly treating with lung disease, so we are very slowly weaning. Constant communications, how are things going, checking markers. So I think, to me, it is not going to be one, like we may have guidelines. I don't have those, like we need more data, and I rely on our scientist colleagues to give us more guidelines about like, can we have ballparks of, after 2 years or 3 years of this, you can start with this. I don't even know what to start. I started with calcineurin inhibitor, wean on a patient who is on calcineurin inhibitor, JAK inhibitor, steroids. So it's really depends on many factors. Yeah, I mean, I might try if everything is going okay.
I have a question.
Can I have one comment? Give one comment. I think nobody of us really knows, because there's very little data to back this up. And the problem here is also that there's very little to guide on. So your HRCT findings may reflect a combination of damage and inflammation, and it's very difficult to take that out. I suppose that at least subclinical inflammation, whether this is visualized by elevation of IL-18 and/or other mediators, can be helpful in this. But I would be very, very careful.
I just want to add a quick technical note that if you are on any of the monoclonal antibody-based IL-18 blockers, you can interpret commercial IL-18 assays. Cannot. They interfere with the assay. There are some companies, maybe some in this room, that are developing reagents to be able to detect IL-18 levels. despite the presence of the therapeutic antibody. But so if you're on MAS825, the IL-18 level you get is probably not interpretable, so you don't send them. And you don't have to take my word for it, but I guess right now you do. Dedeoglu, which is the recombinant binding protein, does not, but is not available for single INDs.
That's very important, Scott. And in addition to that, the levels that I talk about may not be representative to the levels that in any of the other labs, because it's non-commercial assay, and we need to cross-validate that. And there's an initiative now from Pes and Cara to do this. But there may be ratios that convert our IL-18 levels in the levels that you find in your lab, but they are probably not the same. So 1200 here in the Netherlands is not the 1200 here in Cincinnati or in Philadelphia.
I have a question about your study. When you have patients that relapsed, did you recheck their IL-18s and were they high again?
Yes.
So, yeah, quickly. So within a month, it was very high again. Okay, how high? How high? Like range?
The range is extremely variable, but at least in the thousands. Yeah.
If you're done with questions, then thank you so much.